Hello everyone, this is Dr. Pritpal Singh Matreja and MD in Clinical Pharmacology from CMC Ludhiana. And in the previous few videos, I have been highlighting upon the drug development, the informed consent, protocol designing, and the last one I was doing was the types of research processes where I covered up till the case control studies. So today we'll be proceeding further, obviously with a basic overview of what uh, all these studies are, what is an observational study, what is an experimental study, culminating into a pyramid which shows the highest level of evidence for an evidence-based medicine that includes a meta-analysis or a systematic review. So we'll start with this the presentation where we were talking about case control study, and we'll continue with this presentation beyond further, but because it has been a long time, and I believe we must have a recap of what is already is done. So what I was trying to emphasize in one of my last series was that we were talking about the types of research processes that were there. And to have a research process, the first thing that you need is you want to have a good research question. So the two guidelines for a good research question could be either you follow the mnemonic FINER or you follow the mnemonic PICO or PICOT. So FINER, where when we talk about a good research question, FINER is feasible, interesting, novel, ethical, and relevant. Whereas if we are talking about PICO format, which includes the population, intervention, comparison group, outcome of interest, and sometimes timing is added to it. So it becomes PICOT. Now, an example is cited out here where we are talking about a patient who is 65-year-old, and this is our population, and we are talking about the use of an influenza vaccine, which is an intervention. We want to compare it with non-vaccinated population, that is a comparator group, and we want to assess the risk of developing pneumonia, that is the outcome. And then we go further beyond to specify the timing. We want it during flu season. So that helps in framing our research question based upon this PICOT format. Now, we started with the structure of research being an hourglass model where we tend to follow the EMRAD model, where it stands for Introduction, Methodology, Results, and Discussion model, where we start with a very broad topic. We narrow down our statements to smaller perspectives, and then our methods and results are aligned to those aims and objectives. And once we have the results, we go for a discussion where we take a broader perspective into the view. So these are the various types of research that we were talking about: analytical, applied, fundamental, quantitative, qualitative, conceptual, empirical, observational, experimental, primary, and secondary. By far, we tend to mostly focus on two types of, we mostly do quantitative studies, and in this we either go for an observational study or an experimental study. So this study could be a primary study where we are looking for an observational or experimental study, or it could be a secondary study. Now, in the primary study, the observational study could further be subdivided into descriptive and analytical. Descriptive studies are further divided into case reports, case series, descriptive cross-sectional studies, and analyticals are case control or cohort, where we have a comparator group. And we have an experimental study where we go for basic, which means for animal experiments, and clinical, where human beings are involved. Secondary research process involves the meta-analysis and systematic review. So we go with each one by one, a flowchart just to depict the same. And there is in the basic difference between the descriptive and analytical study is, in descriptive study we don't have a comparator group, whereas in analytical study we have a comparator group. And once we go for an intervention in this, it becomes an experimental study. There is a thin line of demarcation, or let's say a bridging gap, for descriptive and analytical studies, and this is a cross-sectional studies. Few authors tend to cite cross-sectional study in descriptive study, whereas few other authors tend to cite cross-sectional studies in the analytical studies. So we start with the first observational study, the descriptive study, that is a case report where we are trying to evaluate or we are trying to describe a single patient or maybe a single drug. And this generally, most of the time, it tends to include the rare causes and we try to identify new syndromes or new side effects. But there are problems associated with this particular case report that you cannot generalize it, and you could not or you cannot give a statement of causation when you're talking about a case report. We cited a typical case report that was published in Journal of Medical Case Report published in 2020. Going beyond that case report, the next level of studies or the next group of studies that comes under descriptive studies is the case series, where we go for a collection of patients, which might be 2 to 10 or even more than that, where we are trying to study either a single exposure or we are trying to study a single outcome. Now, this is basically useful for quantifying, but it tends to only provide a clinical description. An example of a case series where we talked about published in case reports to nephrology, we are talking about a case series of gastrointestinal tuberculosis in renal transplant patients. Then somewhere in between the analytical and the descriptive study comes the analysis of secular trends. This is mostly an ecological study, and it just tends to examine the trend that could be either it could be a trend related to exposure to a cause or disease to its effect, and whether that trends coincide or not, it is totally hypothetical. Vital statistics and record linkages are used. So this is basically just what we are trying to do out here is we are trying to provide evidence either for or against a hypothesis. And the major drawback of this particular analysis of secular trend is it cannot control the confounding variables. An example of analysis of secular trend where we are trying to find major depression in the siblings with major affective disorders. Published in Journal of Psychiatric Research. Then we go for a cross-sectional study. Cross-sectional study, I told you, could be either a descriptive study or it could be a analytical study. So when we are talking about a descriptive study, it tends to study the prevalence and distribution of a particular disease. More often it is called a cross-sectional survey or a prevalence study. And when we talk about the socioeconomic characteristics of the people where we are trying to cover the entire population, that takes the form of a census. Now, it has its own advantages and disadvantages. The basic advantage of having a cross-section study is it gives you a snapshot, very quick, simple, and tends to find out the prevalence. And it is said to be the first line of epidemiological research. Again, as with other descriptive studies, you cannot establish the causality associated with this particular type of studies. An example of descriptive cross-sectional study, we have assessing the prevalence of complementary and alternative medicine use in patients visiting UPMCI center. Then we have another group of studies. We were talking about analytical studies. Now, analytical studies tend to differ from descriptive study where we have a comparator group. This is one of the major features that tend to highlight this particular type of studies, and it tends to establish causes or risk factors to a particular problem. Now, this comparative cross-sectional study tends to investigate association and risk factors, and it also tends to evaluate the outcomes in the same time. And this particular study could determine association. An example of analytical cross-section study of a study done in Thailand, where it was done to study the anemia in rural areas. Case control studies, we have now the basic case control studies is as is named, there's a case and there's a control, and we have a disease condition, and we are trying to look at the differences of exposure. So it tends to determine the relation between risk factors and disease, and it is possible that you could study multiple risk factors in this particular area. Even you could even study rare diseases because it is retrospective study, and this retrospective study is based on interviews and questionnaires. Now, because it is a retrospective study, it has its limitation. The limitations are the information that is given on this retrospective study could be non-valid, and there is always a problem with the selection of control. That is the major hindrance with this particular case control study, and we tend to evaluate the results in terms of odd ratio and outcome. So as I told you that case control study, the event has already occurred and we are going back. So we are looking backward and we try to compare the difference in the cases and controls based on the risk factor, whether it was present or not. So what we try to do out here is we try to study the odds ratio, and it is basically the odd of disease in individuals exposed to unexposed. So we look at this particular situation, we have a disease situation, and we have whether the risk factor was there or not. And let's say we have a table out here where though 120 patients or 120 people who were exposed to a particular outcome developed the disease, 90 did not develop the disease. Similarly, 70 of the non-exposed developed the disease, whereas 200 did not develop the disease. So outcome of odds of outcome in exposed is basically those who developed the disease and those who did not develop, a ratio coming out to be 1.3, and non-exposed it's come out to be 0.35. So when we look for the odds ratio, it is odds of outcome in exposed over non-exposed, and the value comes out to be somewhere around 3.7. Just a hypothetical example. And what does this value determine? So this value determines either if whether the odds ratio is 1, the odds ratio is more than 1, or the odds ratio is less than 1. If the odds ratio is 1, that means that there is no association existing between the risk factor and the disease. An odds ratio of more than 1 suggests that exposure of a particular risk factor might increase the risk of a disease, whereas odd ratio of less than 1 tends to say that exposure of a particular risk factor might even reduce the risk of a disease. So these advantages, as we started from the first slide, that it can study rare conditions, you could study multiple risk factors, and you can establish an association. The problem is of selection of controls and validity of the information, and you cannot do it for diagnostic tests. An example of case control study where we are trying to establish a association between the diet and risk of ovarian cancer. So a particular type of diet leading to ovarian cancer and a particular type of diet not leading to ovarian cancer. This is what has been studied in this particular study. The other group of study is the cohort study. Now in the cohort study, we tend to identify a subset of population, a cohort, and we tend to follow these patients over a period of time to look into the outcome. So what is the difference between a case control and a cohort study? In the case control study, we had the outcome and we were looking for exposures, whereas in the cohort study, we have the exposure and we are looking for an outcome. So this cohort study could be a prospective study as well as a retrospective study, and it tends to give a reliable causal association. But the major problem with this particular study is it tends to require a large sample size and the duration of the study is quite long. These studies are also called as incidence studies or follow-up studies, and if we compare it with vis-a-vis with the cross-sectional studies, they were called as prevalence studies or cross-sectional surveys. There are various advantages of a cohort study. It tends to determine the incidence. It is good for rare exposure and you can study multiple outcomes, whereas disadvantages is time consuming, not good for rare diseases. There is always a problem of non-response and dropouts, and you cannot study multiple exposures at a particular period of time. So this is how the cohort study goes. We have a population, we select a cohort of people in this, and we look for certain risk factors that were present in one group of cohort and the rest for another subgroup, and we try to study whether those with the how many of those with the risk factor developed the disease and how many of those without the risk factor developed the disease. So we tend to calculate the relative risk, which is incidence rate among those with risk factors upon incidence rate among those with no risk factors. So we have a risk factor and we want to look into the disease. So the incidence among exposed out here would be those with the disease over the total number of cases, and incidence among non-exposed would be those with the disease among the total number of cases. So this comes out to be somewhere around 0.29 and 0.12, and when you calculate the relative risk, it is 0.29 divided by 0.12, which is equal to 2.4. Now what does this 2.4 stand for? This 2.4 simply means that if now what we do is we again calculate the relative risk in terms of 1 or more than 1 or less than 1. If the relative risk is 1, that means there is no association between the risk factor and outcome. If the relative risk is more than 1, exposure increases the risk of outcome, and if the relative risk is less than 1, then exposure decreases the risk of outcome. An example of cohort studies has been sorted out here, and we look into the difference where we are talking about the disease situation that has already occurred, and we go look into the risk factors, that is a case control study, and we take the risk factors and look for this disease condition, that is a cohort study. The second group of studies are the experimental studies, and in the experimental studies we had two groups of studies. There were basic studies and clinical studies. The basic research is done on animals, whereas the clinical research is done on human beings, and the randomized clinical trials are the most reliable proof for causation. That is one of the major advantages of doing this particular study. And out here, if we tend to differentiate it with observational studies, in the observational study, you only had a comparator, that too in a case control and cohort study. And when you have an intervention also, then it becomes a randomized control trial when you try to follow that intervention. So out here, in the investigator controls the therapy, randomization is the major strength, but it involves ethical issues and is expensive. You are looking into the intervention and then comparing two groups, and this tends to have a most reliable proof for causation. Uh, Sample study, a sample randomized study is done. We look into the study population, we go for sampling, and we randomize, we select a sample population, and we randomize this particular sample population into two groups. One group is the experimental group, which receives the intervention. The other group is the control group, which does not receive the intervention as is suggested by the study. You tend to collect the data, follow the patient, and then you compare what was the result. This is an example of a randomized control trial where we are trying to look into vitamin D supplementation in older people to optimize the bone health. Going beyond the primary research, now we look into the secondary research process. In the secondary research process, we have two further types of study. These are meta-analysis studies and systematic review. Both of them are almost similar, except for when we go for a statistical approach to combine data derived from systemic review, it becomes a meta-analysis. So meta-analysis as such is a statistical analysis of collection of analytical results for purpose of integrating the findings. So what does this meta-analysis do? It tends to identify the various sources of variation, provides an overall measure of effect, combines data of two or more randomized controlled trials. It tends to provide precise estimate of treatment effect. The advantages are that this particular meta-analysis has greater statistical power and is a confirmatory data analysis. Disadvantages are difficult and time consuming. So to conduct a meta-analysis, what we tend to do is we fix in a criteria where we want to study, let's say, comparison of a two group of drugs, and there are a lot of studies done on it, but we want a conclusive evidence. So we go for a meta-analysis where we combine a lot of studies, and we tend to go for selection criteria. We tend to exclude out studies which do not fulfill the criteria, and the other studies that are left in this particular study design are taken into consideration, and statistics is done, statistical analysis is done, and we estimate the effect of treatment. The disadvantage of meta-analysis is that it is quite difficult and time consuming. This is an example of meta-analysis present during the COVID time, where we are talking about SARS and MERS, and we are looking into the viral load dynamics, the duration of viral shedding, and infectiousness to look for conclusive evidence. So, coming to the systematic review, this is a comprehensive review of all the relevant studies on a particular topic, and it combines all the data that is published or unpublished. Now, the advantages is that it is low cost and comprehensive as compared to meta-analysis. We go back to meta-analysis. Uh, it had a greater statistical power. Out here we are just trying to have a comprehensive review, and this the disadvantages are that this is time consuming and it is always not easy to combine various studies. I was talking about a pyramid where we talk about the highest level of evidence, and it's this pyramid starts with a case report, case series, analytical studies, and then we go for a highest level of study, that is the experimental study, where now why do we want to go for an evidence-based medicine? Because there are a large number of diseases and therapeutic options that are available, and we have to keep ourselves updated so that we can keep on adding to our information resources and we remain competent enough. So these are the various research designs that we need to talk about, and for a good research, coming to this, we should have a clear research purpose, we should elaborate research procedures, there should be clear design and limitations, it should be valid and reliable data, it should be systematic, logical, empirical, and replicable. Then only, if it is not replicable, then our research has not been done effectively. So this comes to the conclusion of types of research processes, where I started with an observational, I started with the differentiation of an observational and experimental studies, and then further I elaborated each one of these observational studies and experimental studies. I hope I have been able to clear the plethora or clear the uh, doubts regarding these types of research processes. And if there are any doubts that you feel you have, you could give me. You could put this on a chat box, and I'll definitely get back to you. So that's all from me, uh, and I hope to see you next time again. So till that time, wishing you all have a good day and a great year ahead. Thank you so much.